Good morning and good afternoon, everyone. Actually, it's the very late time in Korea. So my name is Sang-Yeon Kim from Seoul National University College of Medicine. I will chair this plenary session 4. In this session, the Professor Bae will give us a talk on the title of risk factors for small vessel disease on Asian perspectives. Professor Hee-jun Bae is a professor of neurology, Seoul National University College of Medicine, and Seoul National University Bundang Hospital. 5 years ago, he was commissioned to be a chair of a regional cardio-cerebrovascular disease center of Gyeonggi province, designated by the Korean government. He is currently and deeply involved in the government policy related to the systemic care of stroke. Professor Bae, please.
Thank you, Chairman. Good morning, good afternoon, and good evening, ladies and gentlemen. First of all, I'd like to mention that it is my great honor and pleasure to be here, talk about the risk factors of cerebral small vessel disease. Next slide, please. I'll start my presentation with talking about the 5 manifestations of cerebral SPD and its pathogenesis. After then, I'll discuss risk factors of each manifestations of cerebral SPD and proceed to the ASEAN perspective. I also present the result of our recent analysis on comparisons between the hypertensive and non-hypertensive SPD. Finally, I close my presentation with brief comments on genetics of cerebral SPD as a new direction. Next. Small vessel disease is a disorder of the brain's small perforating arterioles, capillaries, and probably venule. Its radiologic manifestations are recent small subcortical infarctions, white matter hyperintensities, lacunae, enlarged perivascular space, and several microbleeds. Next slide, please. Besides several microinfarctions and superficial cortical hemosiderosis and cerebral hemorrhage and brain atrophy can be listed. Next slide, please. This slide is showing the possible pathogenesis of cerebral SPD. A blood-brain barrier dysfunction, impaired vasodilatations, vessel stiffening, dysfunctional blood flow, interstitial fluid drainage, white matter rarefaction, ischemia, inflammation, myelin damage, and secondary neurodegeneration can be listed. And this list suggests that various types of cerebral SPD have different pathogenesis. In this presentation, among the various manifestations of cerebral SPD, I will discuss risk factors of white matter hyperintensity, cerebral microbleeds, enlarged perivascular space, lacunae, and cerebral microinfarction. Next slide, please. White matter hyperintensity is called that white matter hyperintensity of presumed vascular origin, and white matter hyperintensity are highly prevalent in health populations. While not fully clear, subcortical and perivascular white matter hyperintensity may represent the same spectrum of disease. Until now, several population-based studies have explored the risk factors of white matter hyperintensity. The major studies include the cardiovascular health study, Austrian stroke prevention study, Rotterdam study, ERIC, and Framingham study. Next slide, please. Among these 5 studies, 4 studies reported the prevalence of white matter hyperintensity ranged 65 to 96%. As risk factors, age was the strongest one. Although the Austrian stroke prevention study did not report the result on risk factors, and the French study did not examine the independent effect of age and sex. As expected, hypertension and blood pressure were significant risk factors. Interestingly, female had a higher burden of white matter hyperintensity in Rotterdam study, which was replicated in the Prosper study. It is an old statin trial of the elderly high-risk populations. In Eric, Black had a higher prevalence of severe white matter hyperintensity and experienced more white matter hyperintensity progression than Caucasians. Smoking, alcohol, low income, and education were listed as risk factors also. Next slide, please. As mentioned, age seems to be the strongest risk factor. In our analysis of 2,700 acute ischemic stroke patients from the CRCSK registry, which was a multi-center stroke registry in South Korea, the standardized coefficient of age is highest among the risk factor, as you see, more than 5 times greater than that of hypertension. Next slide, please. The most recent, maybe the biggest study based on the UK Biobank data confirmed that the effect of age, the standardized coefficient of age was highest among the various risk factors. Next slide, please. Cerebral microbleeds is a histopathologically extravasation of blood products into perivascular tissues leading to the activation of macrophages. These foci of hemostatic-laden macrophages are representative of CMV. CMV are common finding in healthy population. The prevalence of CMV ranges from the 3% to 15% depending on the field strength of MRI. Age and hypertension are 2 most important risk factors. Other less robust risk factors include smoking, male sex, low cholesterol, and ApoE genotype. Next slide, please. As with other biomarkers, the location of CMV may reflect distinct underlying etiologies. In about 8,000 patients from the UK Biobank, CMV was detected in 7%. Among them, 77 had a robust CMV and 18% deep CMV. As you see, age was an independent risk factor for CMVs in all locations. ApoE4 allele and male sex was positively, and BMI was negatively associated with robust CMV. In contrast, hypertension, smoking, and alcohol consumption were associated with deep CMV, but not with the robust CMV. Only age was associated with the infratentorial CMV. Next slide, please. In recent meta-analysis, enlarged perivascular space were associated with the aging, hypertension, lacune, and CMV, but not white matter hyperintensity. And similar to other biomarkers, spatial distribution of perivascular space may reflect distinct mechanisms. Deep perivascular space are likely caused by hypertensive SVD, whereas white matter perivascular space may be more driven by cerebral amyloid angiopathy. Next slide, please. As shown, basal ganglia perivascular space was associated with age and hypertension, and centrum cerebellar perivascular space with age. DM was not associated with both type of perivascular space. Next slide, please. Among neuroimaging features, basal ganglia perivascular space was associated with lacunes, CMBs, and centrum cerebellar semi-oval perivascular space was not associated with any of these markers. Next slide, please. Interestingly, risk factors and possibly underlying etiologies differ by the size of lacunes, as already suggested by the Miller-Fisher a long time ago. In an analysis of MRI data from Eric's study, 13% had lacunes between small and large lacunes, less than 7 millimeters and 8 to 20 millimeters. Age had a similar effect. Black race and DM had significant effect only for small lacunes. Hypertension had a stronger effect for small lacunes, and smoking had a stronger effect for large lacunes. LDL cholesterol had an effect only for large lacunes. Next slide, please. The three main causes of cerebral microinfarctions are cerebral SVD, microemboli, and hyperperfusions. History of stroke, AFib, intracranial stenosis, carotid endarterectomy, vascular risk factors, and age were listed as risk factors. Like other biomarkers, the location of CMI may also reflect distinct underlying etiologies. Cortical cerebral microinfarct may be associated with cerebral amyloid angiopathy, whereas subcortical CMI may be due to the other mechanisms such as hypertension. In the 2,200 elderly patients population from the Rotterdam study, 11% had CMI. The major risk factors were male, current smoking, history of heart disease, and stroke. Among MRI markers, only large cortical infarctions were associated with cortical CMI. Next slide, please. Let's look into the ASEAN perspective. In a total of 1,800 subjects from Singapore, Hong Kong, and South Korea, the prevalence of confluent white matter hyperintensity was 37%, lacunes 25%, and CMBs 27%. These figures are higher than expected from the Caucasian studies. The major risk factors are age and hypertension. You can see the effect of age and hypertension increase with the increased severity of cerebral SVD. In a recent population-based study from China, the prevalence and risk factors of white matter hyperintensity, lacunes, and CMBs were similar to previous Western studies. When you look into risk factors in more details, we could see the interesting findings. Age increased the odds of lacunes, deep and periventricular white matter hyperintensities, and all kinds of CMBs. Men increased the odds of lacunes, any CMB, and deep CMBs. Hypertension, systolic, and diastolic blood pressure increased the odds of lacunes, periventricular and deep white matter hyperintensities, and deep CMBs. DM increased the odds of lacunes, and cholesterol, LDL cholesterol was negatively associated with deep CMBs. These findings are not different from the studies from Caucasians. Next slide, please. Recently, among the 10,000 acute ischemic stroke patients hospitalized to our institution during 15 years, we selected 1,000 non-hypertensives and 2,200 hypertensives and compared them. We compared the location of CMB, SVD regions after age and sex matching. Regarding the white matter hyperintensities, we found anterior temporal and inferior frontal areas were more frequently involved in the non-hypertensives than in hypertensives. The frequency of white matter hyperintensity in other regions were not different. Next slide, please. CMB, previous slide, please. CMBs were predominantly in the occipital cortex in the non-hypertensives in the lower figures. Lacunes were more frequent in the periventricular and the subcortical regions, including in basal ganglia, thalamus, and centrum semi-ovale in hypertensives. Next slide, please. We compared the effect of risk factor between the non-hypertensive and hypertensives. Age, female sex, previous stroke increased the odds of white matter hyperintensities in both of non-hypertensive and hypertensives. Interestingly, the effect of age differed between the two groups. Significantly higher odds of age in non-hypertensives. We know the traditional risk factors cannot explain cerebral SVD completely. The genetics may give an answer. Table 1 shows the genetic loci and genes associated with the cerebral SVD, and table 2, the single gene disorders such as CADASIL, CARASIL, and COL4A1, retinal vasculopathy with cerebral leukodystrophy, and Fabry disease. Recently, the 3CT study reported the association of the variants in the HTRA1 CARASIL genes and NACH3 CADASIL genes with MR-defined extremes of cerebral SVD. Next slide, please. GENIAS is an ongoing study for genetic analysis of young age stroke population in South Korea. The final sample size is around 4,500, and primary focus of this study is 15 Mendelian stroke genes. We enrolled about 1,000 patients and detected clinically relevant genetic variants of 15 Mendelian stroke genes in 13%, quite frequent, most frequently in RNF213 monomer genes, followed by the AB66 pseudoxanthoma elasticum genes, and the variants of NACH3 were detected in 15 patients. Regarding other variants of cerebral SVD-related genes, we could find the none in HTRA1 and Corfo A1, and one in TREX1, which is the gene of retinal vasculopathy and leukodystrophy. In summary, although individual cerebral SBD neuroimaging markers, including white matter hyperintensity, raccoon, and cerebral microbleeds, enlarged perivascular space, and several microinfarctions may have unique mechanisms. Several common features suggest that there are likely shared common pathways underlying cerebral SBD. Regarding the risk factor profiles of cerebral SBD, Asians seems to be similar to our other ethnic groups. Interestingly, as I showed our recent analysis on comparisons of non-hypertensive and hypertensive cerebral SBD, 1/3 of non-hypertensive had confluent white matter hyperintensity, and 2/3 of hypertensive had confluent white matter hyperintensity. Important thing is mean age of non-hypertensive is late 50s, but they are no hypertension. I think most of those phenomenon, white matter hyperintensity, could be explained by genetics. I hope that, I hope that this knowledge will help to identify the potential targets for intervention in individuals with cerebral SBD. Thank you for your attention.
Thank you, Professor Bear. Thank you for your great presentation with the many clinical viewpoint. I don't find any question on the Q&A box or the any mark on the raised hand. Okay, Professor Bear. So the according to your presentation, there is a very important difference between the Asian and the Western countries. The frequency of small vessel disease and the pattern of risk factors. What is the main elementary factors making this kind of difference? Genetic or some kind of the diet habit or like that?
Generally, I think regarding the cerebral SBD, there is no big difference between the Asians and Caucasians, but the prevalence of those features, these features, cerebral SBD markers, may be higher in the Asian people, mainly due to the risk factors. So, but in regarding the non-hypertensive cerebral SBD, there may be a big difference, but we have no study compare the Asians and non-Asians without hypertension, focusing on cerebral SBD. We need them.
Yes, I found two questions on the trading box. The first question is the Professor, can you see the question on the trading box? The first question is the maybe higher, yes, small vessel disease burden may be higher in people from Asia, but risk factors are the same. Is there a higher vulnerability than few protecting factors in Asian persons? Please.
I think it is very similar to your questions. I believe that hypertension, uncontrolled hypertension, may be the most important reason between the Asians and Western countries in the prevalence of cerebral SBD. 20 years ago in Korea, at least in Korea, it is very easy to see the cerebral microbleeds in the middle-aged and elderly hypertensives. But nowadays, it is not easy to find them. But as you expect, in very elderly patients, we can see the cerebral microbleeds very frequently. But 20 years ago, it was very easy to find higher number of CMV burden in middle-aged men or women with uncontrolled hypertension. So I think the biggest part is hypertension between the two ethnic groups.
Okay, thank you, Professor Bae. And the next question is, could you please elaborate on the selection criteria for the genetic study, the gene YAS, the young adult stroke?
Yes, it is the starting point, but we have a plan to look into the outcomes. But as I mentioned, the primary focus is 15 Mendelian stroke genes. So I don't believe these Mendelian variants and Mendelian genes are highly associated with the clinical outcomes. But we also try to get the GWAS data. I think we can look into the association between the GWAS data and clinical outcomes in our young age stroke patients. We have a plan.
Thank you. And the next question is there any scope or plan looking at whether behavioral or the functional markers in addition to genetics you are using can be linked to the different small vessel disease subtypes?
Yes, yes, we can, but we didn't. Yeah. Okay. Yeah.
Can you answer for that? I don't understand the behavior and the functional markers. It means that some kind of the neuropsychological characteristics or the others.
We have functional outcomes. Yeah, we have functional outcomes, but we have no the cognitive outcomes in our young age stroke patients.
Is it enough for the answer? Okay. The last question is if the Korean patients with RNF213 variant present with the large vessel disease or small vessel disease.
Thank you for the good questions. This is also our questions. Interestingly, a fourth of patients with the RNF213 mutation had typical features of Moyamoya disease. 3/4 of those patients has no features of Moyamoya disease. We don't know in the future they develop the Moyamoya disease or not. That is our next question. We have a follow-up plan. We have a plan to follow them up for longer period.
Okay, time's up. Any other questions or comments?
There's
Hugh. Yeah, I found this one sign for the raised hand.
Professor Kim, Marcus has a question. I think.
Yeah, I was just, Edith, very nice talk, thanks. There's this very interesting data, showing how common these NOT3 mutations are particularly in Taiwan, in the general population, something like 1 in 100. of apparently normal people have NOT3 mutations. And do you think that some of these monogenic variants actually contribute to the increase in small vessel disease, in people without risk factors in the Far East?
I don't know, but if we have, the problem is we don't have enough sample size. We have around 5,000 patients data. Finally, we can give the answer, but the 1,000 is not enough to answer the question. Most of mutations were found in just 1 or 2 patients.
But what's interesting about this data is there's data, I think it was really Julie Rutten from Leiden who showed this first, that if you looked at these big public databases, that about 2 in 100 people in Europe had NOT3 mutations, which was much more than 2 in 1,000, which was much more than we expected. But in Taiwan and the Far East, it was something like, it was 10 times as many, about 1 in 100. So it would certainly be worth following that up if you have any databases to look at that. It's a really, to me, it was a really surprising but really intriguing finding.
Probably we can see that data 2 years later in the another VASCO meeting. Last, it's time up. I will close this session and it's the time to move the next one.